I'd like to thank the ASNA Organizing Committee for inviting me to give this talk on the latest update on MS drugs. It's truly an honor to be here. So I'm just going to put up my slides. So ladies and gentlemen, managing MS regionally is therapeutically challenging, more so because many of the on-label therapies are currently not available. As reported in this study recently by the Atlas of MS, by Professor Solomon's group, we find that there are numerous barriers. For example, there are barriers with regard to the access, lack of awareness about the disease, the lack of access to healthcare, specialized neurologists, as well as the cost of treatment. So in this talk today, I hope to cover these three main areas. Firstly, I'd like to give you all an update about the MS treatment strategies and the evidence for high efficacy treatments for relapsing MS. And I'd like to share with you the very exciting news about MSIF off-label and essential medicine list guidelines and the results of the WHO essential medicine list application. And I'd also like to finish off by sharing with you about the evidence for off-label rituximab. I have tailored this talk for what is applicable regionally. Ladies and gentlemen, over the last couple of years, the treatment armamentarium of MS has expanded to nearly 20 over drugs. We started 30 years ago with the injectable interferons and glatiramer acetate, and since then we have moved on to the first infusion monoclonal natalizumab, alantuzumab in green, ocrelizumab, and obinutuzumab just last year, 2022. We also have the first orals, which were released in 2010, fingolimod in blue, teriflunomide, dimethyl fumarate, and then followed by the first pulse therapy, cladribine, the most selective S1P receptor and modulators such as siponimod, ozanimod, and ponesimod, and of course, the first in its kind BTK inhibitors, evobrutinib, with its phase 2 trial just completed this year. So currently, I just put up this slide to show you some of the recently completed high efficacy treatments, namely cladribine, the B and T cell depleter, this with FDA indication for relapsing MS as well as active secondary progressive MS, ocrelizumab, an anti-CD20, which has been indicated for CIS, relapsing MS as well as secondary progressive MS, and the first drug that is been approved for primary progressive MS through the ORATORIO trial, ofatumumab, an anti-CD20, approved for CIS, relapsing MS, and active secondary progressive MS, is the first anti-CD20 that can be used subcutaneously, and of course, obinutuzumab, 6 monthly infusions for relapsing MS and anti-CD20. So currently there are 10 on-label DMT classes made up of you can divide them into the low efficacy interferons, glatiramer acetate, teriflunomide, the modest efficacy cladribine, S1P receptor modulators, the fumarates, and the high efficacy ocrelizumab, ofatumumab, natalizumab, and alantuzumab. Now these therapies may be given as maintenance therapy, escalating when one DMT doesn't work, or as immune reconstitution therapy, such as alantuzumab, cladribine, and the anti-CD20s, where clinical efficacy extends beyond the period of active treatment. So what is the mechanism of action of these DMTs? For those of you who are interested in neuroimmunology, this may be useful. Most of the current DMTs act via mechanisms that target the adaptive immunity, which is very much in the periphery here, such as natalizumab, which blocks the trafficking of lymphocytes across the blood-brain barrier, the S1P receptor modulators that block the egress of lymphocytes from the lymph node, the anti-CD20s, which act on the CD20 receptor and deplete B cells, the immune reconstitutions agents such as alantuzumab and cladribine that deplete selectively and non-selectively the T and B cells. Now, currently we have a new class of drugs, very interesting, which is acting not only periphery but also centrally, the BTK inhibitors. They act on the BTK enzyme, the butyrylkyrosin kinase enzyme, and what they do is they act on the peripheral adaptive immunity as well as the innate immunity driven by microglial activity, thus acting not only on inflammation but also progression. and potentially may help patients with progressive as well as relapsing MS. So all treatment guidelines, ladies and gentlemen, advocate for early treatment, with DMTs for active relapsing MS as defined by clinical relapses as well as MRI activity. However, the choice of treatment may depend on a number of factors. For example, the choice of treatment needs to be individualized and based on a number of factors, such as what's the disease activity like? Is the patient having high disease activity or low disease activity? Patient factors. Is the patient a female? Is she planning for pregnancy? What's the risk of them being non-compliant? What's the patient's preference? Do they want an oral therapy rather than an injectable therapy? What are the associated comorbidities? We also need to personalize therapy based on the monitoring. Can the patients come for the blood watchers, which are necessary for alantuzumab? What may be safety concerns? For example, what's the drug tolerability of this patient? What's the cost? What's the access? As well as what are the risks of infection in this patient? What's their hepatitis B status? What's the TB quantiferon? So there are a number of factors that determine treatment. It is also important for us to do prognostic profiling before starting patients on treatment, because some patients may have a number of poor prognostic factors, such as male sex, age, comorbidities. They may have more frequent relapses with poor recovery, brainstem and cord involvement, or they may have high lesion load on the brain and spinal cord at onset or at follow-up, and may benefit possibly from early initiation of higher efficacy treatment. So, what are the two most common treatment strategies in patients with relapsing remitting MS? One is that of an escalation strategy, where one starts with a low or modest efficacy treatment, and then if there's breakthrough disease, one goes on to higher efficacy treatment. So you may start with a teriflunomide, interferon, or glatiramer acetate, and then if the patient shows disease activity, upgrade to a more efficacious drug such as natalizumab, the S1P receptor modulators, anti-CD20s, or try immune reconstitution therapy. Or the other strategy is to try an induction strategy, where you try a higher efficacy treatment such as short pulses of alantuzumab or cladribine, or an anti-CD20 as maintenance or natalizumab, and then follow them up. And if they do well, you continue the medication. Or in case they do poorly, you may want to upgrade to another drug in a different class. So the aim of treatment here is actually to reduce the relapses and prevent lesions on the MRI, and hopefully reduce disability progression. So what is the evidence for these high efficacy treatments? Now, this is a very nice study from the Danish group that shows with high efficacy treatment, the probability of first relapse is reduced in patients who take high efficacy treatments as compared to medium efficacy treatments. And this is another very nice study from the MS base and the Swedish registry that also shows that if you start high efficacy treatment earlier rather than later, these patients, the relative risk of developing disability progression is reduced. And here, the high efficacy treatments that were used were rituximab, ocrelizumab, and alantuzumab. So what is the evidence for the high efficacy treatments? Which drugs are considered as high efficacy treatments? Now, this is a very nice network meta-analysis that looked at the pivotal trials of MS in disease-modifying therapies, and it produced a heat map of efficacy class probabilities. And you see at the top of the map are drugs such as alantuzumab, ofatumumab, ocrelizumab, natalizumab, cladribine, and fingolimod. In the pivotal trials, majority of these high efficacy treatments that I've mentioned reduced the relapse rates by about 50 to 69%. In a more recent network meta-analysis published this year, in terms of annualized relapse rates, the monoclonal antibodies such as alantuzumab, ofatumumab, and ublituximab, and natalizumab and ocrelizumab outperformed the S1P receptor modulators and cladribine. And of course, you can see interferons and teriflunomide at the bottom of the network meta-analysis. What about disability progression? In terms of confirmed disability progression at 6 months as measured by EDSS, this forest plot from the meta-analysis shows the monoclonal antibodies alantuzumab, natalizumab, ocrelizumab, and ofatumumab outperforming the other drugs, including the latest release ublituximab. And of course, the other drugs at the bottom of the network meta-analysis. So I just wanted to share with you a slide on what these drugs look like. We have the anti-CD20s, ocrelizumab. We give it as an induction, subsequently 600 milligrams every 6 months for relapsing MS, and of course it's the first class of drugs that can be used for primary progressive MS. Watch out for infusion reactions, hypogammaglobulinemia, infections, and malignancy. Ofatumumab, the first anti-CD20 that can be used as subcutaneous injections. I find this quite a useful drug to use. It's used as an induction, following that subcutaneous injection every month, and it's indicated FDA for CIS, relapsing MS, and active secondary progressive MS. Similar side effects in terms of injection site reactions and hypogammaglobulinemia. The pulse therapies, alantuzumab and cladribine. Alantuzumab, the first year, 12 milligrams per day for 5 days, then subsequently in the second year, 12 milligrams per day for 3 days, indicated for highly active relapsing MS, as is cladribine. It's a pulse therapy, so you treat for 2 years. Side effects are infusion reactions, autoimmune thyroid disease, membranous glomerulonephritis, ITP, strokes, and infections. There have been some reports of hemorrhagic strokes at the onset of taking alantuzumab. Cladribine acts on B and T cells as pulse therapy, indicated for highly active relapsing MS, active secondary progressive MS. It produces lymphopenia, so you have to watch out for varicella zoster. There have been some reports of one of the commonest viral infections associated with this, and of course, some reports of malignancy. So when using high efficacy treatments, what are the common side effects that we need to be watching out for? I've just summarized some of them. Watch out for infusion reactions with the monoclonals that you give as infusions. Watch out for infections, opportunistic reactivation of TB, hepatitis B, opportunistic infections like PML, cardiac effects with the S1P receptor modulators, malignancy, secondary autoimmunity with alantuzumab, and hypogammaglobulinemia with the anti-CD20s. So let's come now to the exciting part, access. If you look at this report from the Atlas of MS, about 72% of countries cite barriers to accessing DMTs. 48% of countries report problems with continuous provision of DMTs. Furthermore, the Atlas reports many low and middle income countries do not have any on-label DMTs or any high-efficacy DMTs such as natalizumab, alantuzumab, and ocrelizumab. This is very similar to what we see in the ASEAN region. Instead, off-label DMTs such as azathioprine and rituximab are more available in these health systems, including the essential medicine list. The cost of high-efficacy treatments is also more expensive than off-label rituximab and azathioprine. So data from the Atlas of MS in this recent publication goes on to show that 40 to 70% of countries in the world are reported using off-label treatment for MS, and most commonly in the yellow bar, rituximab and azathioprine. So what about the ASEAN region? Many of the collaborators are here in the audience. In this study, in this survey, we've also found that many countries in ASEAN do not have access to high-efficacy DMTs, such as monoclonal antibodies and oral cladribine. Instead, access to off-label treatments such as azathioprine and rituximab are more commonly used in this region. The commonest drugs used here in this region are interferons, teriflunomide, and fingolimod. So off-label treatments, what are they and how do we use them? Off-label treatments are treatments approved for other conditions but not specifically for MS. Off-label treatments like azathioprine and rituximab are more readily available and affordable in health systems and may provide a treatment option where other DMTs are unavailable or unaffordable. This publication provides some general principles about the ethical use of off-label treatment, and the most important thing or the most important caveat is off-label treatments are driven by the need to protect a person's health. So, realizing these challenges, the Multiple Sclerosis International Federation submitted an application to the WHO for inclusion of a number of on-label MS drugs onto the essential medicine list. Now, the essential medicine list is a list of medicines that all healthcare systems globally look at for basic drugs that should be available to patients with a specific disease in a particular country. Now, this application was rejected, and the WHO asked for more evidence to look at both on-label and off-label drugs, namely azathioprine and rituximab. As such, two panels were convened to come up with guidelines for the use of off-label MS-DMTs, especially for low and lower middle income countries, and another panel for the MEM panel, which is the MSIF Essential Medicine List panel, to look at drugs for both on-label and off-label to be submitted to the WHO to be included in the EML. Now, these panels came up with guidelines for off-label azathioprine and rituximab, looking at randomized controlled trials and non-randomized controlled trials for the MALT panel, using pairwise meta-analysis, and the MEM panel came up with guidelines for essential medicines for MS to be submitted to WHO. They looked at all DMTs on-label and off-label, and they included randomized controlled trials using a network meta-analysis. So this panel was made up of a diverse multidisciplinary group, including patients with MS, and utilized the GREAT evidence decision framework to make recommendations, and were guided by the methods share from the McMaster's University, the Cochrane Group, and collaborators from the WHO, and was endorsed by multiple neurological organizations worldwide. So what are the results of this panel? So for the MALT panel, the guidelines for use of azathioprine and rituximab, both rituximab and azathioprine were recommended over no treatment for relapsing forms of MS. Rituximab was recommended as an appropriate alternative to a wide range of other DMTs. Azathioprine was considered an appropriate alternative only where on-label treatments were not accessible due to very limited evidence available. But this, ladies and gentlemen, was the best evidence available at this time. Rituximab was considered superior to azathioprine, and the desirable effects of rituximab were judged large compared to interferon and glatiramer acetate and moderate compared to natalizumab and dimethyl fumarate. What about progressive forms of MS? Rituximab was recommended over no treatment for active progressive MS, but there was insufficient evidence to make a recommendation for or against azathioprine for progressive forms of MS. So what about the MEMP panel? The final group of drugs recommended to the WHO to be included on the essential medicines list were cladribine, rituximab, square box with ocrelizumab, and glatiramer acetate. Why were these final medicines chosen? Rituximab, because of the long dosing interval, and it's already listed on the WHO EML, commonly used in pediatrics. Cladribine, because of the short treatment period, low risk of rebound. Glatiramer acetate, because of very low monitoring. Safety in pregnancy and breastfeeding. So here's the exciting news. As of July 2023, the WHO for the first time has endorsed medicines for multiple sclerosis on the essential medicine list. This recommendation by the WHO included rituximab, cladribine, and glatiramer acetate onto the EML based on evidence for efficacy and safety for the MS indication. It further stated that the list is an important tool for achieving universal health coverage, providing guidance to government, health facilities, and procurers on which medicines are best valued in terms of benefits for individuals and communities. It further states that given the evidence and the increased affordability of rituximab and availability of biosimilars, so I stress that biosimilars, it was prioritized over on-label alternatives as an essential medicine to treat both relapsing and progressive forms of MS. So what is rituximab? Rituximab is an anti-CD20, partially humanized. It's less humanized than its brothers, ocrelizumab and ofatumumab. And it targets the CD20 surface protein on some of the B lymphocytes and acts mainly on the adaptive immunity in the periphery. And of course, biosimilars are available. At this point, I want to share with you one of the latest randomized controlled trials looking at the efficacy and safety of rituximab, the REFUND trial. Now, this trial came out after the panel, the MEMP and the MALT panel, looked at the meta-analysis for inclusion of azathioprine and rituximab. Now, in this study, we see across the board, rituximab outperformed dimethyl fumarate in terms of relapse rates, no evidence of disease activity, and it had better retention rate in terms of adverse events compared to dimethyl fumarate. So this tells you indirectly where you can position rituximab above dimethyl fumarate. And of course, infusion reactions were the main side effect that was seen with this drug compared to GIT and flushing with dimethyl fumarate. So in this recent publication, so what's the safety of rituximab? Is it safe? I'll just go back one slide. In this recent publication in 2021, authors looked at 300 over patients with MS and found that rituximab was relatively safe as compared to some of the other drugs, and it provided that the risk of infections, immunoglobulin levels, and neutropenia is monitored carefully. Infusion reactions, which are usually manageable with pre-medications with a protocol like this, as well as hypogammaglobulinemia and neutropenia were some of the common adverse events. So what dose is effective if we are going to use rituximab? In the pivotal Olympus trial and the REFUND trial, doses of 1,000 milligram were given as induction, followed by 500 to 1,000 milligram every 6 months may be effective. And the important thing here is there's no rebound, as opposed to fingolimod or other monoclonals such as natalizumab. So ladies and gentlemen, now with the EML result, what is needed is country-wise as well as regional follow-on actions. So I'd like to share with you the Multiple Sclerosis International Federation. It provides advocacy tools if anyone wants to improve access situation in their country. They provide templates, letters for reaching out to your Ministry of Health or the press, and they are able to provide speakers and slides to talk about this topic and offer tailored support. So please contact Dr. Joanna Lawson at this email if you're interested. They also offer for training grants, for example, the MSIF grant and the Dupree grants for those who want to do studies and train in countries with MS centers. The MSIF is keen to foster collaboration between patient organizations and clinicians and wants to hear what would be useful in a regional and national setting such as ASEAN. So to conclude, future treatment strategies may include not only these factors that I mentioned to you, but affordability, and may also include off-label treatments for the first time in their decisional algorithms. So ladies and gentlemen, early treatment is important. Just to summarize, early high-efficacy treatments may be beneficial. The MS drugs are now on the WHO EML. Advocacy at regional and national country levels is needed. Off-label options such as rituximab exist. So with that, I'd like to thank the MSIF team led by Dr. Joanna Lawson, WHO representatives and all important collaborators, including those not pictured on this slide, and all regional and global organizations for this tremendous work, which I hope will help our regional MS patients access treatment soon with follow-on regional and national actions within ASEAN. Thank you very much for your attention.